This meeting is now being recorded.
Hello, students. Welcome to week 10. Today we're going to be talking about the fetal head. So hopefully you've already done the online portion of the normal fetal head. We're going to start off like we have been with everything else, with some normal anatomy, and then we'll go over them. So I'll give you some time with each slide so you have a minute to write your answers down. So we'll do those first. So we'll start. All right, so we'll go over the answers. If you heard any noise during that, I apologize. It was my cat who was trying to climb on me. Hopefully it didn't interfere too much. All right, so start with the first image. So what's being measured and what's the normal measurement? So we are measuring the nuchal fold, and anything less than 6 millimeters is considered normal. So anything over 6 millimeters, we would be concerned about Down syndrome or any other kind of chromosomal abnormality. So less than 6 is ideal. The X marks anterior or posterior fetus. So, excuse me, this is marking the anterior fetus. My pointer here. So these are the choroid plexus here. So this is what makes that spinal fluid. So those echogenic kind of teardrop shapes. So the point of the choroid plexus always points to the front. And then the back of the choroid plexus, we see the lateral ventricle here and kind of the bottom of those choroid plexus. So this would be the cerebellum, and this is a transverse cross-section of the fetus, of their head at the level of the cerebellum. Name the measurements. So you guys are old pros at this. So the green is the biparietal diameter, and the blue is the head circumference. So that biparietal diameter is the leading edge measurement, and then that head circumference is measuring all the way around the outside of the skull. All right, so this is the thalamus. This is another transverse cross-section of the fetus. So the thalamus is that structure that we cross when we are measuring the biparietal diameter, so that area right in the middle of the brain. The X marks the anterior or posterior of the fetus. So this is the posterior. So when we're looking at this image here, we can use the thalamus as our guide. So we're a little bit lower in baby's head than the level of the choroid plexus. So if we're here, we can tell that this is the posterior because the thalamus, so it kind of forms a triangle together with the fulx down the middle. So the point of the triangle points backwards, and the base of the triangle, so the wider part of the thalamus, points forward. So that's how we know this is posterior. You can also see a little bit of the posterior lateral ventricle too, so that's a good indicator that this is the back, not the front. So this is also the thalamus. We're again in a transverse view. Looking at the head, we can see a really pretty picture of the cerebellum as well. And what are we measuring here? And what is a normal measurement? So this is the cerebellum. And as we know, the cerebellum is gestational age dependent. So if this fetus is 20 weeks, then the cerebellum, plus or minus, should be about 20 millimeters. This is called the TCD, or the transcerebellar diameter. The X marks the anterior posterior fetus. So let's talk about the thalamus again. So we can't really see the choroid plexus, so we know we're a little bit lower. We can see the thalamus, so that point of the triangle is pointed this way, and the base pointed this way. So we know the base is the anterior, so this is anterior. And also we know that the cerebellum is posterior, so this is a good indicator as well that we're not posterior, but we're anterior. So this is the cavum septi pellucidum, so that kind of box-like shape that's seen in the anterior portion of the brain that almost looks like an interruption in the Leitfalks. Very closely related to the corpus callosum. So anterior, posterior fetus, so same image as before. So cerebellum, very clear. That's in the back of the brain, so we know that this is posterior. So what are we looking at here? So this is the posterior lateral ventricle. Again, we're in a transverse plane to the head. So this area here is what we measure when we're measuring the ventricles in the brain. We should see this choroid plexus within the structure. So this area right here is the very tip of the choroid plexus, but this is the posterior lateral ventricle. So what's being measured and what's the normal measurement? So we're just posterior to the cerebellum, so that's the cisterna magna. And anything less than 10 millimeters is a normal measurement. So anything that's over that may be suspicious for too much fluid within the head, which is never a good thing. So specifically, we're looking at the cerebellum here, but specifically we're looking at the cerebellar vermis. So this is the kind of the portion that fuses the lobes of the cerebellum together. So it's a little bit more echogenic than the other tissue of the cerebellum, and it should be right in the middle of that peanut. So that's the cerebellar vermis. This is important that it's present. We'll talk about that later as to what happens if it's not. So this image, it looks like we're pointing to the thalamus, which we are, but we're specifically pointing to the area in between both portions of the thalamus. So this would be the third ventricle. So we can't see this normally if the brain is normal, only if there's ventriculomegaly and there's extra fluid in the head. It'll appear as a anechoic cyst between the two portions of the thalamus. This is the area of the third ventricle. So echogenic teardrop shape here, we're looking at the choroid plexus, so transverse view of the head again. We can see that both of them bilaterally are filling that ventricle. So that's where we want to see them. It's nice and echogenic and homogeneous, which is the look we want when we're looking at the choroid plexus. So what is being measured and what is a normal measurement? So this is a trick question. The CSP is not measured. So this is that area in the front of the brain that is closely related to the corpus callosum. Some people do measure the CSP, but this should not be something that should be measured. Sorry, I'm the instructor that gives you trick questions. So what is being measured and what is the normal measurement? So this is the lateral ventricle, more specifically the posterior lateral ventricle. And anything less than 10 millimeters is considered normal. So when we're measuring the posterior lateral ventricle, we want to go perpendicular to the ventricle itself, and then we want to cross the very tip of the choroid plexus when we're measuring. This will give us the widest part of that ventricle. So what are we looking at here? So it looks like a midline structure. So it's the midline falx, so that separation between the hemispheres all the way down the head. We are at the level of the choroid plexus here, and we can see the falx nicely between both of them. So these structures here and here, so this is the anterior lateral ventricle. So this posterior part and this anterior part are technically connected. They're both the lateral ventricle, but we should not see them together in the same plane. If we did, then we would think ventriculomegaly. But the horns of the anterior lateral ventricle should be kind of bordering that choroid plexus, which is right here. So this here, we are looking at the area of the nuchal fold, posterior head here. So in this area right here is the skin behind the neck. That's what we would measure if we're measuring the nuchal fold. So we're looking at the cerebellum again, and these arrows are pointing to the lobes of the cerebellum. So we talked about the vermis, which is this echogenic area right here, and then the lobes are what border that on either side, making that peanut shape. The X marks the anterior or posterior fetus. So we were talking about if we were at the level of the choroid plexus, the points point forward and the base points back. So this would be the posterior aspect of the fetus. So we're looking at here, so the area directly posterior to the cerebellum that's anechoic is the cisterna magna. So again, we're in transverse to the fetus in this view. All right, so that's it. So we're going to move on. We're going to talk about some embryology. So there are three segments that make up the brain. So we have the prosencephalon, which is the forebrain, the mesencephalon, which is the midbrain, and the rhombencephalon, which is the hindbrain. So these are the three segments that make up the brain early on in embryology. Neural plate development will complete around 18 to 23 weeks. So it takes a little while as compared to some other structures that are done by 3 weeks or 4 weeks. So the brain takes quite a bit of time because it's a pretty complex structure, obviously. So when we're talking about the embryology of the brain and what we can see on ultrasound, we can talk about the rhombencephalon. So if we remember, this is the hindbrain. So the rhombencephalon images as an anechoic structure in the posterior fetal head that's visible around 8 to 10 weeks. So this arrow here is pointing to the rhombencephalon in this little embryo. And then we have the rhombencephalon right here. So it almost looks like baby is missing part of the brain in this image. It's just the way we're catching it. And here too, it just looks like there's something missing. But it's not. It's a normal structure. So 8 to 10 weeks, we should see this on the fetus. When this is done developing in the 18 to 23 week range, the rhombencephalon or the hindbrain will turn into the medulla pons and the cerebellum. So our corpus callosum, cerebellovermis, sulci, gyri, migration of the germinal matrix, and myelination happen after 15 weeks. So these are all important aspects of brain embryology that happen after 15 weeks, so within the second trimester. So moving on to 18 to 20 weeks, we have the development of the corpus callosum that completes. And that will include the cavum septum pellucidum or septi pellucidum, septum pellucidum. Everyone says it differently. So this is why on ultrasound we can't see the CSP until around 18 weeks. So if someone were to come in for an early fetal survey before 18 weeks, we may not see this area, which is really important to see when we're doing a fetal survey to make sure that the brain's developing the way it should. So we really shouldn't be doing a fetal survey before 18 weeks unless they're coming back for a follow-up. So the 3 to 16 week area is the critical period of brain development. So just like anything else, teratogens and exposure to toxic substances and all that stuff has a huge impact on the brain between the weeks 3 and 16. So we want to obviously avoid anything like that in pregnancy, period, but this is the critical period for the brain. So this is just kind of a diagram of the embryology and the development of the sulci and gyri. So they should image at 28 weeks. So the sulci and gyri are those kind of indents in the brain that make up that kind of classic brain tissue that looks like the tissue is kind of intertwined between itself. So in ultrasound, we should be able to see those at 28 weeks. If we don't, it could mean certain conditions, and we'll talk about that later. So lack of folic acid can lead to central nervous system anomalies, so anything within the brain or the spine. This is why you see moms taking this supplement when they're pregnant or even before they become pregnant to kind of get a jump on it to make sure that their body has enough for proper development of the central nervous system. So talking about the eyes, when we're talking about the head, we talk about the eyes as well. So at week 28, the optic vessels develop. That should not be week. It should be day 28. Optic vessels develop. Vesicles, excuse me. End of the first month, the vesicles become optic cups. So kind of the areas that will hold the eyes eventually. Continuous development happens until 48 days. So the lenses, the eye pigment, so blue or brown, and then the final eye itself. And then after 48 days, so the eyes start in the fetus lateral and dorsal. So almost like a bug. So they sit on the side of the baby's head. So they move from there to the midline where they reach their normal location by the end of the first trimester. So by the end of the first trimester, they should be in the right spot. So this is the face we'll talk about specifically. So this is just a image of the embryo's face, what it looks like before everything kind of gets into place. So this structure here and this structure here, those are the eyes. So we are before the end of the first trimester because they're still lateral. These areas here will become the nostrils, and then this will hopefully close and become the lip, top lip. So the 5th week, the neural crest cells migrate into the head and neck area, forming the brachial arches. So there are 6 sets of arches when we talk about these brachial arches. So the first, also known as the mandibular arch, this is what develops into the face and maxilla, mandible, incus and malleus, in the ear, maxillary artery, and trigeminal nerve. So this is an important arch, obviously. And then second, arch develops into the face muscles. So continuing on with the 5th week, the frontal nasal prominences swell, forming what become the upper mouth, nose, and maxilla. So these are the frontal nasal prominences here. So still going on the 5th week here. So we were just talking about this, the frontal nasal prominences. These move from their lateral origin to eventually ending at the midline of the face. So just like the eyes. So they kind of start lateral here, and they slowly will move in towards the midline. Along with the eyes, they'll go kind of in the same, at the same speed to get to the middle of the face where they should be normally. So this is just a diagram of the development of the face. So we have the eyes out here as these black structures. And as we continue in the diagram, we can see that they're moving closer and closer to the midline, or to where they should be. And same with the portions of the nose and upper lip. So they start lateral with eyes, and then slowly they move in to make the normal nose and top lip. All right, so we'll talk about the abnormal fetal head. So lots to talk about here. So we'll start with the brain itself. So we'll talk about microcephaly first. So microcephaly is simply a small head. So diagnosis is based on biometry. So if that BPD and HC are below 2 standard deviations of what it should be for gestational age, then microcephaly will be questioned. So it's not usually considered a single clinical entity, but a symptom of etiological disturbances. So when we think of microcephaly, a lot of people will think of Zika. So that is something, a virus that causes microcephaly in fetuses that are exposed in the womb. So that would be an environmental factor. Prenatal exposure to drugs, exposure to chemicals, genetic factors, and single gene defects can all cause microcephaly. So we have a normal baby over here with a typical head size. So baby with microcephaly, so this dotted line is the typical head size to compare. So 2 to 3 standard deviations below the mean gestational age. So this would be probably 2 standard deviations below and then 3 or more. So this is a baby with a very small head or severe microcephaly. The smaller the head, the worse the prognosis. This just increases the risk of neural compromise. So obviously there's not as much space in here for a normal brain to form. So that kind of explains why the severity gets worse if the microcephaly is worse as well. So sonographic appearance, so the disproportion between skull and face. So there will be a sloping forehead. The brain will be small, like we were just talking about. The ventricles may be enlarged just because the brain is not functioning appropriately. So here we have a normal profile. We have a nice forehead, nasal bone, and we have our face structures here. So this is a baby with microcephaly. So this is the same view of the profile, but we can see how flat the forehead looks here. And it almost looks like the face is bulging out. It's just because the head is not proportional with the face and causing this kind of sloped back because the head is small. So on the other end of the spectrum, we have macrocephaly. So this is a baby with a large head, 2 to 3 standard deviations above the mean. So microcephaly and macrocephaly, it's very important to remember that diagnosis of these two entities requires accurate dating. So if someone's dating didn't match what the baby was measuring, we would think that the baby was measuring either small or big. But if that dating was off, it may be that the baby is just normal, but we just don't know that because the dating is incorrect. So sonographic appearance, so usually enlarged ventricular system, so very enlarged to the point of hydrocephalus, the fluid, large collections of fluid within the brain, and a bulging forehead. So opposite of microcephaly where it slopes, we're now bulging because the head is much bigger than it should be. So we have our normal profile here, and then we have our macrocephaly. So you can see how the forehead is bulging. You can actually see back here, look at this huge collection of fluid in the head. So this is their ventriculomegaly. So that big head and bulging forehead. All right, so anencephaly. So this is the most common neural tube defect. So this is a condition that happens when the cervical end of the neural tube fails to fuse. So the top of the neural tube won't fuse and partial development of the brain will happen. There may be very little functioning brain tissue, but sometimes there's none at all. Some have some functioning brain tissue with a rudimentary brain stem. But if there is brain tissue present, it's going to be very little. This is a condition that's always lethal. Excuse me, a baby can't survive very long without a brain, because obviously that kind of what am I trying to say? Kind of influences all of the other bodily functions. The incidence is about 1 in 1,000, so it's not super rare, but it is something that's very lethal and very awful when you find it on ultrasound. So this is just a diagram of a normal baby and an anencephalic baby. So this is, we have our normal brain and our brainstem. So this is a fetus or a baby with, they have the head itself, but the cranial vault is gone and the brain is gone. We just have the brainstem left. So this portion of the brain never formed, leading to anencephaly. So anencephaly looks a little bit different in the different trimesters. It's one of those anomalies that's so severe that we can see it in the first trimester. So we'll talk about how it looks in the different trimesters. in the first trimester, an anencephalic baby will have an absent cranial vault, so there will be no bones of the head. The crown rump length will be reduced. So if you think about it, that brain tissue and that cranial vault is missing. So that's a big portion of the crown rump length, so that baby's head. So if that's all missing, the crown rump length is going to be shorter than it normally would. Neural tissue is exposed, so there's no cranial vault. It's just that brainstem, if any, there, no tissue, so that's exposed neural tissue. And the loss of normal head contour, with the orbits marking the upper limit of the fetal face. So the orbits are usually where the head stops. So it makes the head look abnormal, along with all of the other findings when we're talking about this. So second trimester, the rudimentary brain tissue is covered by a membrane, but not bone. The head is going to be flattened because there's little to no brain tissue. The eyeballs will appear like they're bulging because they're usually the upper border of the head. And then again, no cranial vault or skull present. So third trimester, there's usually polyhydramnios. So this baby doesn't have appropriate neural function, so they're not swallowing correctly. So it's going to lead to extra fluid. And interestingly, there's a high degree of fetal activity. So that brain tissue is firing off those neurons at a crazy rate, and these babies have a lot of activity going on. So when we talk about anencephaly, one of the main characteristics are those bulging eyeballs. So they're called frog-like on ultrasound. So when we're looking at this image here, you can see that these are the eyes, and then there's nothing above it because we have no brain tissue or skull. So it makes them look bulging and almost like a frog. So this is a 3D here. We have those bulging eyes and then nothing really above it. And then this is the baby born. You can see how those eyes look like they're bulging. So we have our normal profile over here, and then we have our anencephalic profile. So obviously very abnormal. We have the eye, nose, lips, and chin, and then that's it, nothing else. There are usually associated malformations. Spina bifida, cleft lip and palate, clubfoot, and omphalocele are common. When we were talking about folic acid earlier, so this is a neural tube defect. So folic acid helps with the development of the central nervous system. So this or a folic acid supplement greatly reduces the occurrence of anencephaly to happen. So acrania, so this is the absence of the cranial vault or the skull. So a thin membrane will cover the brain, but there's no skull. So this is different from anencephaly in that there is brain present, it's just that the skull is missing. So sonographic appearance, we have no fetal skull. Brain tissue is present, but it does appear unorganized because there's nothing to kind of hold it in place. You can see how this looks like a bulging forehead, but this is just brain tissue that is not kind of contained by a cranial vault. Again, polyhydramnios in this case because of the lack of swallowing function because of the interruption in the CNS function. We have our normal profile here, and then we have acrania. So this is the face, tricky to see because everything's abnormal, and then we have this kind of bulge here. That's the brain without that skull. And then we have a transverse view of the head. So we have our nice normal head, cerebellum, thalamus, CSP, and then acrania. So you can see when I was saying that this brain tissue looks disorganized, this definitely does not look anything like this. So I'm not sure which structures are where, but this is all just brain tissue. This is a newly born infant with acrania, so we can see that the brain is there, but it's just covered by a thin membrane, and we don't have that skull to keep it in place. So what's the difference between anencephaly and acrania? So I was just saying this earlier. So anencephaly is missing brain tissue. Acrania is missing the skull. So acrania still has brain tissue, just missing the skull. Anencephaly is missing both brain tissue and the skull. So anencephaly, we have absent brain tissue and frog eyes. And in acrania, we have absent skull and disorganized brain tissue. So if we see brain tissue above the eyes that doesn't have a cranial vault, it is acrania. And if there's no brain tissue present, that's anencephaly. So hydrancephaly. So this is complete or near complete absence of the cerebellar or the cerebral cortex, and that's replaced by fluid. So this is usually destruction of a normal third trimester brain. You can see this crazy image here of all this fluid in this head. The thalami, lower brain centers, and cerebellum are usually intact, but the rest of the brain tissue is usually replaced by this fluid. So sonographic appearance, we obviously are going to have a large collection of fluid in the head, little to no recognizable cerebral cortex. So we have some tissue here, who knows what that is. Everything else is just replaced by fluid. We have our normal compared to abnormal, so our nice normal brain, and then same view here, just with hydrancephaly and a bunch of fluid replacing that brain tissue. So there is one well-known cause of hydrancephaly that we've talked about before in a different class. I don't know if you guys remember. So this is, hydrancephaly is usually a third trimester finding, so which is unusual. A lot of stuff starts in development and continues on, but this is a brain that turns abnormal. So maternal toxoplasmosis exposure is a well-known cause of hydrancephaly, excuse me. So that replacement of the brain by fluid. So we were talking about toxoplasmosis, how we don't want to clean the cat litter when we're pregnant because of those kind of abnormal exposure. We don't want the exposure to the abnormal substances within cat pee. Other causes of hydrancephaly, cytomegalovirus, herpes, and carbon monoxide exposure. So anything that can kind of harm the baby in the third trimester that's pretty significant will cause this hydrancephaly. All right, so we're going to move on. We're going to talk about holoprosencephaly. So this is something that is pretty severe in the fetal head. There are different types of holoprosencephaly that we'll talk about. But holoprosencephaly is a variety of abnormalities of the brain and face that happen because of incomplete cleavage and rotation of the embryonic forebrain. So this will result in a single centrally located ventricle, and the falx will be missing. So this is a pretty severe abnormality. There are multiple causes of this, one of them being poorly controlled diabetes. So we know how bad diabetes is in pregnancy, and also teratogens. So just like anything else, exposure to abnormal substances can cause bad things to happen. So there are three types of holoprosencephaly. So we have lobar, semilobar, and alobar. So these types are defined by the degree of separation of the cerebellar or the cerebral hemisphere, excuse me. So we'll talk about these three. So this is alobar, semilobar, and lobar. So lobar, so almost complete separation of the hemispheres, although the frontal horns, lateral ventricles, and thalami are fused. So you can see this head obviously looks abnormal. We've got fluid around the outside, but we still can see a little bit of the separation of the hemispheres here by the falx. And this is very clearly the thalami. And this looks like it's part of the cerebellum back here. So not still recognizable a bit, but obviously still abnormal. So we have our nice normal transverse head here, and then we have lobar holoprosencephaly over here. So semilobar, we have partially separated brains. So we're starting to get more and more abnormal looking. So we have the thalamus in the middle here, which is fused. No other really indications that the falx is present. So we're talking about holoprosencephaly. So we have that single large ventricle. So this here, fluid filled. This looks like it's supposed to be the cerebellum back here. So this would make this a cisterna magna. So again, obviously very abnormal. So our nice normal head, and then we have semilobar holoprosencephaly. So a little bit of fluid here, not a lot of indication of separation between the two sides of the head. And then alobar. So this is the worst form of holoprosencephaly. So there's a single common ventricle and the thalami are fused. So this is one big ventricle here. This is the thalamus here, which is fused. So obviously very abnormal looking head. We have our normal head here. And this is alobar holoprosencephaly, our thalamus, very abnormal, and that big single ventricle here. So this is the table of the degree of severity. So we have our normal, lobar is the least severe, and alobar is the worst. So lobar, we have partial separation of the hemispheres. Semilobar, we have less, and then alobar, we have none. So like microcephaly, the prognosis will depend largely on the severity of holoprosencephaly. So abnormal facial malformations accompany holoprosencephaly. So the failure of the sagittal division of the prosencephalon will create abnormal facial structures. These are usually seen with semilobar and alobar holoprosencephaly. So the towards the worst end. They're rarely seen in the lobar form. So this is an image of a baby with what's called a proboscis. So it's just kind of a piece of tissue that sticks out of the head. It almost looks like a nose, but there's no bones associated with it. So it's just this kind of flap of tissue. And then cyclopia is another one that is common with holoprosencephaly, or two eyes. This is two eyes in this case that are much too close together. Obviously, there's a proboscis up here in this image. So we'll talk about cyclopia. So presence of a single median bony orbit with a fleshy proboscis above it. So this is the most severe facial malformation that we would see in a fetus. So we have that single eye with the proboscis. This is a baby with the single eye and the proboscis right above it here. So do you remember what trisomy is associated with the proboscis? So trisomy 13, so one of the, or out of the big three, trisomy 13, 18, and 21, this is the worst trisomy. So this is a pretty severe finding. So this is, this can be associated with trisomy 13. So we'll talk about sebocephaly. So this is hypotelorism associated with a normally placed nose with a single nostril. So hypotelorism has to do with eyes that are not in the correct position. They're a little bit too close together. And then the nose is present, but it just has one nostril. So that's the definition of sebocephaly. So another abnormal facial condition that can happen with holoprosencephaly. So we'll talk about agenesis of the corpus callosum. So the corpus callosum is the connection between the two cerebral hemispheres. So if it's not there, or if it fails to connect, then the two sides of the brains can't talk to each other. So it can be partially there or it can be completely gone. This is something that's highly associated with other conditions. So 80% of cases are associated with other anomalies. Some, just for example, trisomies 18 and 13, hydrocephalus, Dandy-Walker malformation, Arnold-Chiari malformation, and holoprosencephaly. So how does this look on ultrasound? So if we remember, the cavum septum pellucidity, septi pellucidity, is very closely related to the corpus callosum. So if that is absent, we're going to assume that there's something happening with the corpus callosum. So either it's completely gone or it's partially there. And the lateral ventricles are going to appear teardrop shaped. So you can see how this almost looks like a teardrop here. Usually we can't really see this part of the ventricle in this plane. So we have our normal, we have our CSP here, that box-like shape that separates the falx towards the front of the head. And then this is a brain with agenesis of the corpus callosum. So we can see the falx traveling from front to back and with no interruption, no CSP is present. So this is a tricky condition for parents to kind of deal with if this was found in their fetus. So if the CSP is absent, it doesn't always mean that things are going to end up poorly with the fetus, but it could mean that things could end up really bad. So this is something that we can't tell a patient definitively, black and white, if this is going to be a normal functioning baby or extremely abnormal. So this is a really kind of frustrating diagnosis sometimes for those parents to hear, because it is such a gray area that they don't know until the baby's born, until the baby starts functioning, how this will affect them down the road. So Dandy-Walker malformation. So this is an anomaly of the posterior fossa with cystic dilation of the fourth ventricle, complete or partial agenesis of the cerebellar vermis, and elevated tentorium. So this is something that looks that has a very specific look on ultrasound. So I was talking about when we were looking at the normal images about the cerebellar vermis. So that's what connects the lobes of the cerebellum together and how important that is. So this is the condition where it's absent. So we're going to look at this and look how the cerebellum appears when it that is not present. So Dandy-Walker ultrasound appearance. So superior displacement of the cystic fourth ventricle, displacement of the